I am Dr. Thomas Antony. I would be your mentor today at StudyMRCP. So this is basically for part 2. This is last minute revision. So this will help you to guide through your exam, particularly in this topic. So what are we going to discuss in this 1 to 2 hour session? So we would be discussing more about cardiology. So this is we have scheduled this class to make sure that we cover all the important topics. So major topics will come first, like the cardiology, respiratory. Cardiology, we will be discussing about acute coronary syndromes, then arrhythmias, ECGs, heart failures, channelopathies, respiratory, COPD, NIV management, asthma, pulmonary embolism, ILD, and ABPA. This itself will have some 19 questions each. So this is a major chunk of MRCP Part 2 exam. So it's important that you know in and out of cardiology. So we will be discussing a summary of what you should be knowing. And we have medical ophthalmology, which is important because even though it is 3 marks along with a palliative, the 3 marks, 3 questions itself would decide. So most of the students pass or fail by marginal marks. So these smaller questions will help you in that way. So oncology, we'll be discussing about emergencies and paraneoplastic syndromes. So moving to cardiology, this itself will be 9.5% of the total marks. So basically in cardiology, in examination approach, read every stem as ECG pattern and hemodynamics. So if a patient presents with certain complaints, you feel that there is an ECG shown, make sure you know the clinical status of the patient, whether the patient is hemodynamically stable or not. So name the rhythm, or there will be a signature rhythm also. Then let the stability decide whether to treat or observe. This is a general concept. We'll be discussing most of these in detail. So stable versus unstable is the first hope. Okay, shock or chest pain or heart failure, reduced GCS, then we might have to keep a synchronized DC shock, whatever be the rhythm. So this is the concept. So even though we have the diagnosis based on the ECG, we should know whether the patient is stable or not, because that determines what to do next. In case of inherited disease patterns, so usually inherited disease patterns, you know that this will be usually in young people, and if there is a syncope or family history of sudden death and a signature ECG changes like in Brugada syndrome or Hocum or long QT syndrome. Heart failure, the ejection fraction drives both prognosis and device choice because the classification itself is based on the ejection fraction. So if the ejection fraction is low, it is considered to be a poor prognostic factor. So we have a different set of management strategies for patients with reduced ejection fraction and preserved ejection fraction. So we have know the discriminators that can flip the answers. MRCP, if you see most of the questions, there could be a misleading. So that is the way experts prepare MCQs, because they will keep a discriminator or a distractor in the question. So you know that the patient is having such and such complaint, like a patient is having an SVT. Now, what is the drug of choice? So we have the adenosine, and so in somewhere in between the paragraph, they would be mentioning the patient a previous history of asthma. So that is where the things change. So post PCI QRS change, where you need to observe the new murmur plus shock, it could be a mechanical complication. So we will be going through a little bit in detail. So systematic ECG reading. How do you read ECG when you get a question? So first is the rate. What is the rate? Whether it is a bradycardia or a tachycardia. So 300 by the number of large squares between the R's. Okay. Rhythm. Now we have to know whether this is a regular or irregular. Okay. So P before every QRS if it is there. QRS after every P. So these are things you should look for. In the axis, lead 1 and AVF. the left or right axis deviation points towards a conduction or a structural disease. Intervals, now we have to see the PR interval, QRS interval, then QT. So whether there is a block or a bundle branch block, is there any channelopathies involved, or is it because of any correctable causes like drugs? STT changes with chambers, ischemia, strain, hypertrophy, or electrolyte effects. So we are going to recognize certain patterns here. So this is AVNRT, where there is a fast, regular, narrow, no visible. You see, these are all supraventriculars. So if you see AVNRT, it's more of a narrow complex. Again, atrial fibrillation, it is again a narrow complex with no visible peak. You have, but irregular rhythm. You can see there is irregularity in rate also, and also in amplitude ideally. So in ventricular tachycardia, broad, see, that is the difference between supraventricular tachycardia and ventricular rate, because in ventricular it's more of a QRS involvement, so there is a wide QRS complex here. So how do you manage the peri-arrest tachycardia, tachyarrhythmias? So this is the algorithm that we follow. So if there is a tachyarrhythmia means there is a fast rhythm here. So first we have to see, we know we have identified the pattern in ECG. Now we have to see whether the patient is having clinical stability or not. So if the patient is clinically unstable, always go for a synchronized DC shock. And if the patient is clinically stable, okay, so then you have to look for the complexes. So if it is a narrow complex and it is regular, then we are dealing with conditions like AVNRT and AVRT, or even an atrial flutter. Okay, in such cases where it is more of supraventricular, then you have first a vagal mania. So this goes sequentially. So first you'll have a vagal mania, like a carotid massage. Then we'll go for IV adenosine when required. Okay. So if it is a broad complex, we know this is a ventricular. So VT until proven otherwise. So we have amiodarone, and we have to refer the patient for expert help. Okay. Now, if it is irregular, then we are dealing with AF with or without aberrancy. So in such cases, depends. So the details of which we'll be discussing further. So in rate control, we have beta blockers and CCBs. Okay, so in case of structural heart disease with broad complex, treat as ventricular tachycardia, not SVT with aberrancy. Okay, so there is a structural heart disease and a broad complex. So there are two options. One, it could be a ventricular origin rhythm, or it could be supraventricular tachycardia with an aberrancy. So in what they say is that in case of structural disease, you have to consider it as a VT or treat it as a VT. So it is safer to treat as a ventricular rhythm rather than treating specifically for a supraventricular rhythm. Okay, so the pearl here is adenosine trace AVNRT and unmask the flutter, avoid in asthma. Okay, so coming a little bit more in detail about the supraventricular tachycardias. So we have the AVNRT and AVRT. So what are these? So it occurs usually in young, recurrent, abrupt, narrow complex, and it's more of a regular. See, it is similar to all supraventriculars. It is like a narrow complex. It will have a regular pattern without a P wave involved. So this usually happens in young patients, and this keeps on recurring. So once if you get the arrhythmia, you are prone to get it repeatedly. Okay, so in acute stable cases, you can try with vagal manuals. Then, if it is not coming down with vagal manuals, you can give IV adenosine. Okay, So what are the things the patient is pretty conscious. So what are the things you should be advising the patient? That there is a transient assistal or flushing is possible. Okay. So in case of atrial flutter, so again, you can see this will be a regular sawtooth pattern. Okay. So these often comes in the ratio of 2:1 with a ventricular rate of approximately 150. So this is one thing you should consider, because in atrial flutter, it's more of the rate is coming as 2:1. There are other ratios also, but here the ventricular rate is approximately 150. So what is the definitive treatment? So definitive treatment is to ablate the accessory pathway, like a catheter ablation for recurrent AVNRT or AVRT or flutter. So usually these conditions are managed symptomatically, because in most cases these are not life-threatening. So in case of recurrent conditions where it is disturbing for the patient, it is affecting the quality of life, you can go for catheter ablation, which is the available option. So now we have WPW syndrome with AF. So in that, the problem here is we have an accessory pathway. See, the atrial fibrillation means there is a fast transition from SI node to AV node. So in WPW, we have an accessory pathway which carries all the impulses from atria to ventricle. So in the advantage of AF is that AV node itself acts as a buffer. It will slow down the conduction. So what is happening here when there is, if we give AV nodal blockers like digoxin or verapamil, what happens is that the conduction, the effect of AV node is blocked. So when a pathway is blocked completely, the impulses choose to take the alternate pathway which is already present, like in WPW syndrome. So that causes all the impulses which is initially at least partially blocked by the AV node is redirected into the ventricle. So it can lead to ventricular fibrillation. Now you can see this. This is a classical pattern. So here the flutter is usually right atrial. Okay, so you can see the sawtooth pattern. There are 2:1 or 4:1 blocks. Okay, this is a question for you. So this is a 24-year-old who collapses during a rugby match. On arrival, heart rate is 208, BP is 82/50. Lightheaded, monitor shows regular narrow complex tachycardia with no P waves. Then he recovers spontaneously twice before. So what is the next best option for this patient? You can message. So what is the patient having? Okay, so so this patient is having AV nodal reentrant tachycardia. So this is the classical description which we have discussed before. So you know that this is a supraventricular tachycardia because you have a narrow complex tachycardia along with absent P waves. In young patients, so we have to more think in terms of AV nodal reentrant tachycardia. So why? Because he is borderline but not peri-arrest. So why we are? So the question is why we are not going with desynchronization therapy. So here, patient is peri-arrest. So we have to try the vagal manus first, then move on to adenosine. Okay. So DC shock is for unstable patients with recurrent episodes for ablation. Okay, so coming to atrial fibrillation, we have unstable AF, which is a synchronized DC version, cardioversion, regardless of the onset. This is what we have been discussing. So if you have an unstable AF, you have to go for a synchronized DC cardioversion. So in case of rate control, we have beta blocker or rate limiting CCBs. Rhythm control we consider in patients who are younger, symptomatic, or new onset anticoagulate pericardiovascular in such cases. Okay, so we will be slightly discussing it further. So stroke risk we calculate using the chart S2 WAS score guides the anticoagulation. So the bleeding risk is by the Hasbled scoring, and so mostly what happens in special situations, like I've discussed this before, we give instead of adenosine, we give verapamil or diltiazem. So this is because adenosine precipitates bronchospasm. Again, in WPW syndrome, avoid AV nodal blockers. So in rhythm control, we have electrical cardioversion, even medical drugs like flecainide or amiodarone. So in case if the patient is having a structural heart disease, we might have to focus on amiodarone. If the patient is not having a structural heart disease, the drug would be preferably flecainide. So what is Hasbled? So this Hasbled is a score which helps in identifying the patients at increased risk of bleeding. So this is not a determinant whether to start treatment for the patient or not. So this is assessing the risk factors along with the comorbidities or modifiable risk factors, in fact, and assess the risk of bleeding in such patients. So this is a 64-year-old with brittle asthma in fast AF. So 36 hours post-admission, BP of 138/84, no chest pain or heart failure. She needs rate control. So what would be the drug of choice here? See, this is what I have been discussing before. So you know the answer is straightforward because the patient is having a fast AF, 36 hours post-admission, BP is stable. So there is no chest pain or heart failure. So she needs rate control. So what do you prefer? Okay, we'll go into the answer. So here, verapamil is preferred. Why? Because the patient is stable. So if the patient is stable, we go for a rate control. Beta blocker is contraindicated by the severe asthma here. So we prefer here a rate limiting calcium channel blockers. Okay, so again, adenosine treats AVNRT and not AS. So digoxin is a weak. This is for weak for exertional control. Amiodarone for refractory or unstable cases. So we have discussed a few about supraventricular or tachyarrhythmias. Now we have bradycardia and heart block. This is also equally important. So decide pace was observed by symptoms and escape level. I'll be talking about that. So that means whether to intervene or not depends upon the clinical stability of the patient and the escape reliability of the rhythm. So in first degree, we have a fixed long PR interval. PR interval is usually more than 200 milliseconds. And here, every P wave is followed by a QRS complex. So what you see, this is a fixed long PR, which is more than 200 milliseconds. So this is usually benign. Nothing usually happens except for a lower rhythm or a lower rate. And no treatment is usually required for this. So this is the first degree block. Now coming to Mobich type 1, which is a Wengipack. Now we have a progressive PR lengthening. It will progressively increase the PR length and suddenly it drops. Okay, so this is also usually benign. So this usually happens at the AV node. So happening with young healthy adults, athletes who have increased vagal tone. It can also happen even in inferior or MI also. So if we have a type 2, then we have unreliable escape. So here what happens is that in PR interval remains a constant. So it is mostly similar to the first degree block. But what happens? Suddenly a beat is dropped. So this happens usually below the AV node. That means it could be in the bundle branches usually. So this is type 2. I will be showing you the ECG changes later. So now this is an unreliable escape. So in such cases, we might have to go for pacing initially by temporary and then move on to permanent pacing. So reversibles first. So there are a lot of modifiable factors which might be involved, which can reverse the bradyarrhythmias. So it could be a patient might be on a beta blocker or digoxin. It could be ischemia related, like we have discussed before. It could be because of electrolytes like calcium abnormalities or potassium abnormalities. Then hypothyroidism. All those things are the correctables. So when you look at the ECG, you should concurrently think about other reversible causes the patient might be having if the patient is on any medications. Most of these will be usually because of medications. Other things are usually rare. So medications and any possibility of an ischemia is a third, and electrolytes. These are the first things that you should be considering, followed by hypothyroidism. So these are the degrees of heart block. You can see in first degree heart block, there is a fixed PR interval. So nothing need to be done for that. In Morbid's type 1, you have a progressively increasing PR length and then suddenly a QRS is dropped. Usually this is benign. In type 2, you have a fixed constant PR interval and suddenly a drop in QRS. So this requires pacing. So coming to channelopathies and inherited cardiomyopathies. So we have a few channelopathies which you need to know, because one question would be from this for sure. So I have not seen a question paper which is missing one of these. The most favorite question will be on HOCM. So coming to the first channelopathy, that is the Brugada syndrome. So this is a sodium channel abnormality. You have a mutation in SCN5A gene. So what is happening here in ECG? You have a code ST V1 to V3. So unlike in other inherited arrhythmias, these events can occur even at rest, during sleep, or during fever. So in fact, fever can unmask or worsen the ECG pattern. So what do? You have to put on an ICD. So you have a long QT interval. So long QT interval, you have patient presenting with syncope on exertion or emotion. So this is a stress-related issue. So what are the risk factors here? So what happens, long QT have a prediction to predispose or progress into toxicity points. Again, hence avoid QT prolonging drugs. So look for any electrolyte abnormalities in correct sodium or potassium or magnesium. Okay, so in long QT, there is a delayed ventricular repolarization. So like I said before, this is triggered by emotion or exercise. Okay. So sometimes even a loud noise can precipitate a long QT syndrome. So what is the QT cutoff that is mentioned? So in men, we consider corrected QT of more than 40 milliseconds, and in females, we consider it as slightly higher, more than 460 milliseconds. So what do we do for the treatment? So we have options like propranolol or natalolol, which is preferably for congenital QT. Okay. So next we have HOCMs. So this is also important. So in HOCM, again, this is also exertion precipitate. So you can see sudden cardiac death in young with a positive family history. This will be clearly described in the question. So the patient, an athlete, suddenly collapses. So he gives a family history of a sudden cardiac death in the family. So in such cases, think of HOCM. So what is happening here? Here in young patient with sudden cardiac death on exertion, we have ejection systolic murmur louder on convulsion. So we have beta blocker, ICD is high risk. Okay. Now we have ARVs, which is arrhythmogenic right ventricular cardiomyopathy, which presents as RV failure. Then T inversion in V1 to V3, epsilon waves, exercise-induced VT. So all these cases, we have to screen the first degree relatives and counsel on avoiding triggers and competitive sport. So most of these channelopathies have exertion as a trigger. So and for example, I'll give you an example. A patient, a young male who has syncope while swimming or exercise, on ECG have a prolonged QT. So what do you suspect? Possibly this patient might be having a long QT syndrome. Okay. So this is Brugada syndrome. You can see the sharp swing type. You can see the QT, the changes in the pattern here. So ST pattern here. So there is a curved or sharp swing ST elevation in leads V1 to V3 along with a T wave inversion. This is easier to identify because most identify the pattern on basis of the clinical background also. So if you have a long QT syndrome, there is a risk of progression of long QT into retrocessive risk pointers. Okay, so what is the risk factor for retrocessive pointers? Again, it is prolonged QT. You can see the pattern of changing. Okay, so we can see the wave pattern. This is called, the name itself, retrocessive pointers. It is twisting around baseline. So what happens here is the QRS appears to twist around the baseline. Okay. Why is that? Because the amplitude goes on increasing and decreasing. So, okay. So Torsades, the treatment of choice here is IV magnesium, correct potassium, stop QT prolonging drugs. Okay. So why? Because QT prolonging drugs can predispose to retrocessive pointers. So this is a summarization of the important channelopathies. Inherited conditions. So ECG clue in Brugada syndrome, we know that it's a sharp fin type or a curved STV1 to V3 changes. In HOCM, we have a left ventricular hypertrophy and deep Q waves and dynamic murmur. You have an ejection systolic murmur. Then in long QT, you have a prolonged QT and sometimes there will be retrocessive pointers. So most of these clinical scenarios, we have a long QT and a retrocessive pointers if it is a long QT syndrome. So trigger, what is a trigger for Brugada syndrome? Like I said before, even at rest, it can happen even during sleeping or if the patient is having fever. Other things are mostly exertional. In case of long QT syndrome, drugs could precipitate. Low magnesium or potassium, congenital problems also can be there. So in Brugada syndrome, ICD is a choice. Avoid blockers. In HOCM, we have beta blockers, but in case of high risk problem, we have ICDs also. In long QT syndrome, we have to avoid QT prolonging drugs, correct potassium and magnesium. Okay, so this is a question. A 19-year-old man collapses at rest. Now alert. BP is stable. Heart rate is 70. ECG show code ST elevation V1 to V3 with T wave inversion. His brother died suddenly in his sleep. Age 21. Echo structurally normal. So these MCQs are to bring you the idea. So most of the findings would be mentioned in the MCQ. So in practice, in real exams, you might be getting real ECGs also. So interpret accordingly. So there are a lot of points which are favoring our diagnosis. So what would be the treatment of choice here? So we know that the echo is structurally normal. So ICD is the drug. So what is the diagnosis here? We have a Brugada syndrome. So all these things, all these features we have included in this. So why ICD? Because of this is there is a high chance of arrhythmic death here. Okay, because it can progress into VT or VF. Okay. So coming to acute coronary syndrome and its complications. So this is also an important topic. So ST elevation MI, we have ST elevation or new onset LBBP. So in such cases, we have to go for a primary PCI. Okay. If PCI is not available, then we might have to go for thrombolysis. Okay. So in case of NSTEMI, we have to stratify the risk based on the GRACE score. So the GRACE score estimates the patient's risk of death and future cardiac events. So this is kind of like a mortality predictor. So if the patient has a high GRACE score, suggests that the patient is likely to benefit from early invasive strategy like coronary angiography and PCI. So remember that GRACE score is used to risk stratify in patients with NSTEMI. Okay. So once the risk stratification is done, you can give dual antiplatelets and anticoagulation. Okay. Then decide whether the patient is having required to have angiography or not, depending upon the GRACE score. Okay. So what are the first week killers? That means we are going to discuss about the complications of acute coronary syndrome. So initially, in first week, we expect the patient to have a timeline of events later. We have VSD, ventricular septal defect. We have a papillary muscle rupture, pre-wall rupture, or tamponade. Then we have, so these presents usually, because you know that these are all mechanical problems. So there will be a new onset murmur. Since these are main things like ruptures of the free walls or the papillary muscles, you can have shortfalls depending upon the severity. So post PCI ECG changer, then if the patient is stable, isolated QRS widening is a reperfusion. What happens is that when a blocked vessel is opened up, you may see some reperfusion arrhythmias also. So the most common one is accelerated idioventricular rhythm, that's AIBR. So this is because of the transient irritability of the reperfused vessel. So this is usually benign and we need only to observe. Secondary prevention, we add dual antiplatelet, statins, AC inhibitors, beta blockers, and refer the patient for cardiac rehabilitation. So here, when if the patient presents with a sudden hypotension, raised JVP hours after PCI, we have to suspect tamponade or pericardial effusion. So now the ACS pathway, how do we manage patients? This is a flow chart for you to better understand the pathway, what comes next. So if the patient presents with acute chest pain and we have done the troponin and ECG or are in favor or suspicious of acute coronary syndrome, we have the ECG where ST is elevated or there is a new onset LBBP, then we are dealing with STEMI. If there is no ST elevation, then we are thinking in terms of NSTEMI or it could be an unstable angina. If it is a STEMI, then we have to go for primary PCI. If primary PCI is not available, sometimes thrombolysis. Okay, so what if the patient is having NSTEMI? Then as we have discussed before, we have to risk stratify the patient based on the GRACE score. So depending upon the GRACE score, if it is high, then along with the anticoagulation, you might have to go for angiography. If it is low risk, we might be able to settle with anticoagulation and dual antiplatelet. So after this, after we have treated the acute coronary syndrome, now we are looking for the complications. So it can be something like a reperfusion, arrhythmias like a benign one, or it could be complicated ones. Okay. So first week killers where there is a new onset murmur, shock or collapse. We are thinking in terms of ventricular septal defect, papillary rupture, or a free wall rupture or tamponade. Then you have to refer the patient for an urgent echo. Okay. So these are the post-MI complications timeline. So in first 24 hours, we are looking for arrhythmias or cardiogenic shock. 2 to 4 days, patient can have pericarditis or reinfarction. 3 to 7 days, we might have to deal with ventricular septal defect, papillary muscle rupture, free wall rupture. And in 1 to 4 weeks, we have Dressler, LV aneurysm, neurothrombus. New murmur with shock days after MI, think in terms of mechanical complications. So that is what the concept is. If there is a new onset murmur, especially days after, it is unlikely to develop early, then you have to think in terms of mechanical complications like ruptures. So in such cases, refer the patient for an urgent echo. So the timeline is to narrow down the differential diagnosis first. So coming to another important topic, the heart failure. So there could be questions expected from this also. So you have heart failure with reduced ejection fraction. So these are the survival corticosteroids. We have ACE inhibitors or ARNIs, beta blockers, MRAs, and we have SGLT2 inhibitors. So these 4 class of drugs are considered to be survival corset. So why is this? Because this 4 drug classes is proven to reduce mortality. So this is an important or favorite question that comes in MRCP. If they can frame it differently to bring this answer. So what would be the next step of addiction of medication, or what are the drugs which is known to reduce the mortality? So these would be the questions. So here is ARNIs, we have sacubitril or valsartan. Then what happens here is ACE inhibitors or ARNIs can reduce the remodeling. Okay. Now coming to the devices. So if the patient is having an ejection fraction of less than 35%, along with a left bundle branch block, symptoms on maximum therapy, then we have to think in terms of cardiac synchronization therapy. If ejection fraction is less than 30%, you have to consider ICD in case you are suspecting arrhythmic risk. Okay. Now coming to the tamponade, we have the Beck's triad. So the Beck's triad is basically a hypertension, raised JVP, and muffled heart sounds, along with pulses, paradoxes. Refer the patient for echo and pericardial synthesis, because that might be compromising the patient's the pumping action of the heart. So we have valvular emergencies like an acute MR or AR that present as flash coronary edema or shock. Okay. So what is the cause of this acute MR or so this could be because of a papillary muscle rupture, which can happen after myocardial infarction, or it could be even cardiac rupture. So usually these patients present with sudden onset of flash pulmonary edema. So ectopy, it is less than 10,000 PVCs in 24 hours. So if there is a structurally normal heart, you can give reassurance. Now this is the heart failure ladder. This is also an important topic. So in all patients with heart failure and reduced ejection fractions, we are supposed to start on ACE inhibitors or ARBs or even ARNIs. So once the patient is started on that, you have to add the patient on beta blocker. Once, if the patient is still symptomatic or the ejection fraction is less than or equal to 35%, you might consider adding spironolactone or eplerenone, depending on the mineralocorticosteroid antagonists. Then, for further benefit, you can decide on adding SGLT2 inhibitors. So all 4 classes improve survival in heart failure with reduced ejection fraction. So add CRT or IC, depending upon what you are dealing with. If there is arrhythmia or if the patient is prone for arrhythmia, then you have to consider ICD. Okay. So this is a question. A 24-year-old, 24 hours after primary PCI for an anterior STEMI, a patient suddenly deteriorates. This is 24 hours after. BP is 88/54, heart rate is 110, raised JBP, muffled heart sounds, and pulses paradoxes. So what are we dealing with here? Okay, so we have here, you know that it's 24 hours. What is happening? The patient is having hypertension with pulses paradoxes. So this is classical tamponade. What do we have to do? Refer the patient for an echo and pericardiocentesis. So this is a revision of what we have discussed so far. So classify first based, if you see an ECG, see the rate, rhythm, QRS fit, whether there is a narrow complex or it's a broad complex, regularity, then treat the patient based on the stability of the condition. Channelopathy triad, you have young patients presenting with syncope or family history of sudden cardiac death, and along with the signature ECG pattern, like we seen in the Brugada syndrome, where you have a shocking pattern. So devices, when to do devices, when to give devices. If the ejection fraction is less than 35% along with a left bundle branch block, then CRT. If ejection fraction less than 30% along with arrhythmia, you have to consider ICD. Asthma with AF, then verapamil. WPW with AF, avoid AV nodal blockers. All these things we have discussed before. Post-MI, new murmur with shock, you have to think in terms of mechanical complication. Refer the patient for an urgent echo. So now we will be discussing about respiratory medicine. This is another important topic which is given equal weightage to cardiology. That means we have almost 9.5% of the chunk. So in case of the approach to respiratory questions, we have to triangulate based on the blood gas analysis. So most of these questions will have an APG. So depending upon the condition, the scenario. Then chest X-ray and one discriminating blood. So you should not rely on a single evidence to come to a conclusion. So support and titrate NIV from escalate now. So it depends on the condition and the severity of the patient, whether you have to observe the patient or intervene then and there. Now, eosinophilia reframes the case, that if the patient is having ABPA, eosinophilic pneumonia, or EGPA. Hypercapnia, what we have to do in such cases, whether in such cases we have to give a controlled oxygen, requirement of an NIV, normal or rising carbon dioxide in asthma exposure. So these things we'll be discussing. ILD, match pattern to exposure. Always in ILD cases, you have to look for the cause or to identify the causes. So most of these ILD will have some causes. It could be even connective tissue disease associated ILD. It could be exposure related, like in pigeons, if you have seen hypersensitivity pneumonitis, or it is just a general terminology. If nothing is related, we are attributing it to idiopathic ILDs. So how do you interpret the ABC? So if you get an ABC, first you have to check the pH, whether this is acidosis or alkalosis. If it is an acidosis, then there are two possibilities. It could be raised PCO2 or it could be less bicarbonate. So if it is raised CO2, it is more in favor of respiratory. In case of alkalosis, it could be because of lesser carbon dioxide in respiratory or increased bicarbonate in metabolic. So what are the possibilities of reduced carbon dioxide? So this is some pattern which we don't look into much. Most of the conditions in emergencies presents with actually lesser carbon dioxide, like in patients with exacerbation of asthma or patients with embolism, patients with breathlessness because of anxiety. So all these patients will have tachypnea and carbon dioxide washout leading to respiratory alkalosis. So it's important that we look at this pattern also. So metabolic acidosis, check anion gap. If it is raised, look for lactate, ketones, toxins, or urine. Now, COPD and non-invasive ventilation. So this is a very important topic because COPD and non-invasive ventilation is linked quite well. And the questions will be from COPD. So in case of exacerbation, you have to give controlled oxygenation. That means 88 to 92% is a target. If there is evidence of type 2 failure, these patients with COPD will have accustomed, because these carbon dioxide itself will act as a stimulant for the respiration. So that will help them survive. So as we give enough oxygen or excess of oxygen, what would happen is that the drive for respiration is lost, because the most important mechanism of type 2 failure, as seen in COPD, is hyperventilation. So it could be the reduction in the drive. It could be a CNS cause also, like in opiates. So the carbon dioxide will act as a trigger here. So we don't want excess of oxygenation to keep the complete wipeout of carbon dioxide. Now, what are the indications of NIV? So NIV is the first step in patients with COPD who have a respiratory acidosis. If the pH is less than 7.35, so we can wait till 7.25. If it is in that range with an elevated carbon dioxide, we can administer NIV. Okay, now the titration. Persistent acidosis even after 1 hour, increase the IPAP. So what we want to drive the carbon dioxide out. So we have to increase the pressures, inspirated pressures, to drive the carbon dioxide out. We have EPAP, which splints airways. So this will keep the airways open. So when the patient breathes out in COPD, the alveoli collapses early. So if you have EPAP, it will act as a splint. Okay, so this improves the oxygenation. So the concept is, okay, the NIV, I hope you know what an NIV is. NIV has an IPAP and an EPAP, which we call the BiPAP. So we have an EPAP and an IPAP. So what we commonly give for obstructive sleep apnea is something called CPAP, which have only one pressure, single pressure. So here we have two pressures. There's a higher pressure and the lower pressure. The lower pressure is called EPAP. So the difference is the pressure support. The difference between the higher pressure and the lower pressure. The lower pressure, what it does is it will splint the airways, and the higher pressure will force the carbon dioxide out. So for clearance of carbon dioxide, we need IPAP. For oxygenation, we have EPAP. Ceiling of care should be decided early and documented. So in case of acute breathlessness, asthma and NIV. Okay, now this we have to know. In patients with acute breathlessness, acute severe or life-threatening asthma, we have to give the initial oxygen administration, salbutamol, hypertrophy, nebulization, steroids, magnesium, and senior ICU, referral. 10 normal or rising carbon dioxide, exhaustion, refer the patient to ICU and not reassurance. Okay, in case of COPD with type 2 failure, see, asthma is more of a type 1 respiratory failure, whereas COPD is a type 2 respiratory failure where you have an increase in carbon dioxide. So when pH is less than 7.35 and raised carbon dioxide, we have to give controlled oxygen along with a BiPAP. After 1 hour, if the pH is still less than 7.25 or persistently increased carbon dioxide, increase IPAP, so mind it, we have to recheck the ABG PCO2 values. So, see, what is the difference that we see here? In asthma, they did not mention about the NIV and NIV administration. So that is because in COPD patient, it takes a lot of time to, because this is a chronic disease, patient is accustomed to the high carbon dioxide levels. So if you see in asthma, this is an acute episode. In between the episodes, patient will be completely normal. So what happens here is even a slight increase in PCO2, even with the normal range. I have discussed this before. When do you have a low carbon dioxide, when the patient is tachypneic, like in exacerbation of asthma, it is good. Now, if the patient is having a normal PCO2 also in patients with asthma exacerbation, then you have to be careful, because normal is also not good in patients with asthma. In such cases, we have to refer the patient for, that means the patient is going into respiratory failure. So you have to refer this patient to ICU. Next step is intubation. There's no bridging with NIV here. There's no time to waste with NIV, and look and observe things is only for COPD. Controlled oxygenation doesn't matter here in asthma. So acute asthma and ABPA. So this is a close differential. All patients, most patients with ABPA, means asthma, are prone, or ABPA, asthma itself is a risk factor for ABPA. So severity by objective measures. How do you assess the severity? We have PFR. Even in emergency settings, we have to classify asthma based on the severity using the PFR. Okay, respiratory rate, heart rate, carbon dioxide, and consciousness level. In acute severe cases where PFR is 33 to 50%, respiratory rate is more than or equal to 25, heart rate more than or equal to 110, you can administer nebulizations, ipratropium, steroid, magnesium if required. And in life-threatening conditions where PFR is less than 33%, you have to, and or if there is a silent chest, normal or high PCO2, exhaustion, then refer the patient for ICU. In ABPA, we have asthma, central bronchiectasis, high IgE, Aspergillus precipitans. See, if you see a patient presenting with childhood asthma, uncontrolled, even with regular medications, you have to think in terms of ABPA. So how do you diagnose ABPA? There should be a background of asthma or cystic fibrosis. On CT, you'll get a central bronchiectasis, a raised IgE level. So previous guidelines used to mention more than 1,000. Now even 500 is considered enough for ABPA diagnosis. You have positive Aspergillus precipitans. So this is a fungal sensitization. EGPA, this is slightly different from other like ABPA. This is more of a vasculitis. So there again, asthma patient will be presenting with uncontrolled asthma, or even a normal asthma patient also can present, along with the raised ESR fields and features of vasculitis. What are the features of vasculitis we are looking for? Could be mononeuritis. Patient might present with a foot drop, and here ANCA is positive. Okay, so this is the acute asthma severity ladder. So this is important to stratify patients with asthma in emergency, so that we can manage them accordingly. Okay, so moderate asthma, we have PFR of 50 to 75%. This 50 to 75% is compared to the personal best. Okay, so PFR 50 to 75%, patient is talking normally, can give salbutamol, steroids. In acute severe asthma, where PFR is 33 to 50%, respiratory rate of more than or equal to 25, heart rate of more than or equal to 110, nebulizations with levosalbutamol, ipratropium, steroid, and magnesium were required. In life-threatening cases where PFR is less than 33% and a silent chest, normal or raised PCO2. This I am stressing this because sometimes you will get everything normal, and they will mention an ABG with a normal PCO2 also. So we have to look for that. If the patient is having exhaustion, refer the patient to ICU and anesthesia environment. So again, a normal or rising carbon dioxide in acute darkness sickness exhaustion. So these are the flow volume loop patterns that we see. So the green one is considered to be normal. So you can see the red one, how is it different? There is a scalloping. So that is because of the reduced flow volume. So the flow is the forced expiratory volume. So what happens in patients with obstructive airway disease? So obstructive airway disease is something which the patient might be having difficulty while expiring. The inspiration is usually normal. So if you ask the patient with COPD to blow out, the rate or the flow will be less compared to the normal individuals. In restrictive patients, the flow will be equal, normal, or even increased, but the volume will be reduced because they don't have enough air to blow out. Right. So if you see the pattern here, in the dark blue one, it is restricted. You can see the volume is much less compared to the normal. So coming to the eosinophilic lung disease, we have ABPA, eosinophilic pneumonia, and EGPA, previously known as Churg-Strauss syndrome. So again, in ABPA, what are the clues? The patient will be having a background of asthma or cystic fibrosis, along with high IgE eosinophils, and aspergillus precipitans might be positive. What do you give? First line is always prednisolone, with or without itraconazole, depending upon the patient's the severity and depending upon whether you have to reduce the steroid dose. Because this is not for short term, you have to give it for few weeks. Okay. Now we have eosinophilic pneumonia, where we have peripheral. Usually these patients present radiologically have a peripheral consolidation, and BAL will have eosinophilia. Okay. So again, the treatment of choice here is prednisolone. EGPA, we have asthma along with vasculitis features. ANCA will be positive. Okay. And again, eosinophils is very high. Steroids and with or without immunosuppression is the treatment of choice. So this is a practice question. 46-year-old stable yard worker has poorly controlled asthma despite inhaled steroid. Eosinophil says 1.8. Total IgE is markedly raised. Aspergillus specific IgG is positive. Test X-ray is showing splitting infiltrates and central bronchiectasis. So what would be the treatment of choice? So the answer is pretty clear. So this is prednisolone with itraconazole. So again, this is ABPA. We know the triad here. And why? Because steroids control the flare, itraconazole reduces the fungal burden and the steroid need. So what are the traps here? The escalating inhaled therapy alone fails, because sometimes this happens clinically when we are dealing with patients with asthma who are uncontrolled. We go on increasing the medication, and even we move on to the biologicals without addressing the underlying cause. So the patient might be having a fungal sensitization. So if by eliminating the fungal sensitization, patient can get much better. So we here in StudyMedic have a lot of upcoming events. There is programs for MRCP PACES. There is one-to-one courses. You can always contact the operations team for further details. Okay. So in case of acute respiratory emergencies, So pulmonary embolism is the most important question or most relevant question that comes to in terms of MRCP. So the first thing is to identify whether the patient is having a massive pulmonary embolism or if it is a stable pulmonary embolism. So your treatment depends mostly on that. So what is a massive pulmonary embolism? So if the patient is having hypotension, RV strain, then there is a systemic thrombolysis we have. So we have to use alteplase. If it is a stable PE, we can anticoagulate, and depending upon the contraindications, we can use either DICs or low molecular weight heparins. Thrombolysis is not indicated because the patient is clinically stable. Diagnosis so depends upon the Wells score. If the patient is having a low Wells score, you can always go for a D-dimer, then decide on CT payload. If the patient is having a high Wells score, then we have to directly go for CT payload. Okay, so echo shows RV dilatation in massive pulmonary embolism. Provoked versus unprovoked. So this is important because if we have a cause of pulmonary embolism, then we address the cause, patient gets better, you can discontinue the anticoagulation after some time. But if we don't know the cause, then we might have to give for a long duration. And depending upon whether the cause is correctable or not, like in case of malignancies, we might have to give for long duration. Pregnancy, low molecular weight heparin is a treatment of choice. Avoid DOSAs or warfarin. So in case of a suspected pulmonary embolism, now we have to see if the patient is having hemodynamic compromise or not. So here, hemodynamic compromise in case of pulmonary embolism that we are looking at is systolic blood pressure less than 90 millimeters of mercury, or if the patient is in shock, or there is a cardiac arrest due to pulmonary embolism. So again, persistent hypotension due to pulmonary embolism despite adequate fluid resistance. So we have used the term here, persistent systolic blood pressure. If the patient is having BP of less than 90 millimeters of mercury, administering fluid, if it is correcting the blood pressure, then you need not escalate from. Okay, so if it is a persistent systolic blood pressure, if the patient is in shock, or there is a cardiac arrest due to pulmonary embolism, then you have to intervene. You have to go for a thrombolysis. Okay, so then it is considered to be a massive pulmonary embolism. Then we have to go for thrombolysis with alteplase, then anticoagulate. If these things are not there, then stable PE, you can anticoagulate the patient with DOAC or low molecular weight heparin. Here, thrombolysis is not indicated. So coming to the pneumothorax and pleural disease. So again, when pneumothorax comes to the topic, we have to deal with the tension pneumothorax. How do you identify tension pneumothorax clinically? So there will be tracheal deviation to the opposite side. Patient might be in shock because the other lungs and the heart is pushed by the air. What you have to do is immediate middle compression in the second intercostal space. So okay, so in case of secondary pneumothorax, like in COPD or lung diseases, lower threshold to drain and admit. So in case of pleural effusion, we have to decide or narrow down the differential diagnosis based on the fluid characteristic. We have to utilize the Light's criteria to decide whether this is exudate or transient. Okay. So there is a slight change in guidelines. The current guidelines management of pneumothorax based on the BTS guidelines is slightly different from what we were following before. So in the newer guidelines, we have primary spontaneous pneumothorax. Primary spontaneous pneumothorax is something which is not associated with any structural lung disease. So in such cases, most of the cases we can manage conservatively. unless if the patient is symptomatic. So if the if the patient is not symptomatic, clinically stable, or even if minimally symptomatic, and he is reliably on follow-up, then in such cases, you can even manage the patient conservatively. Okay, so you can even discharge the patient after review in 2 days. This is not the practice that we follow, but this is specifically given guidelines, and this is what is followed in UK. So, as a summary, size is no longer an indication of fibrosis. The previous guidelines used to mention that at the hilar level, if it is more than 2 centimeters, we have to intervene. But those things are gone now. Now it is based on the symptoms of the patient. If the patient is symptomatic, intervene. If the patient is having mild symptoms or no symptoms, you can even discharge the patient. Okay. So, and if the patient is symptomatic, what will you do? If there is significant pain or breathlessness, you can either go for nasal aspiration or you can go for small bore chest drain. So it's a small bore chest drain. These patients require admission, not the patients who are not symptomatic. Okay. So if symptomatic and there is physiological compromise, like hemodynamic instability, there is a risk of lower BP, then you have to put a chest drain. In secondary pneumothorax, we have a lower threshold to intervene. Depending upon the severity, we'll have to go for an intercostal drain. Okay. Okay, so again, a 28-year-old develops sudden pleuritic chest pain and breathlessness after a long flight. See, these are the clues that you should pick up. This is not only for the written exams, this can also be kept for other places also. So, long flight. Sometimes they will even mention they travel from Australia in flight. They won't even mention sometimes a long flight. BP is low, heart rate is elevated, SpO2 of 88%. Bedside echo shows a dilated, poorly contracting right ventricle. CTPA confirms bilateral central pulmonary embolism. Okay, so what is the treatment here? We have discussed this before. The patient is having hemodynamic compromise. There is a massive pulmonary embolism. Next option will be alteplase. Okay. Now coming to interstitial lung disease and sarcoidosis. So IPF bar UIP. So what are the patterns seen here? In IPF or UIP, you have basal involvement along with honeycombing, clubbing. So what are the pattern here? So if you assess the patient clinically, patient will be having clubbing. There will be exertional dyspnea and tricough. If you get a CT, which is almost always diagnostic, you have bibasal involvement along with reticulations and honeycombing. Okay, so what is the treatment of choice? Now we have certain medications like antifibrotics like nintedanib or pirfenidone, which can be used for the treatment of IPF. They have modified the use of antifibrotics or extended the use of antifibrotics into progressive ILDs. So this is not only the drug of choice for IPF, this can be even used for all progressive ILDs. So we have sarcoidosis. There is a bilateral nodes present. Patient can present with hypercalcemia, uveitis, erythema nodosum, non-caseating granulomas. So young female presenting with exertional dyspnea, chest X-ray showing hilar widening, sometimes even normal X-ray. There could be skin lesions. There could be other features like uveitis, erythema nodosum. On biopsy, so the treatment, the diagnosis of choice will be biopsy. If there is a lymph node, we can go for endobronchial ultrasound guided biopsy of the lymph node. It will show non-caseating granuloma. So that's how you differentiate from tuberculosis, where you have a caseating granuloma. So the treatment of choice is steroid, no doubt. But when do you treat? So you treat only if the patient is symptomatic, if there is any organ threatening, or if there is hypercalcemia. Now coming to hypersensitive pneumonitis, I have discussed this before. There is an antigen exposure and there is precipitance to the antigens. So there is upper zone change. Okay, so that depends. See, there are patterns of involvement in CTs that we can easily recognize to come to a conclusion. If there is a lower lobe involvement, that means you are dealing with IPF or UIP. It could be NSIP. It could be an acute hypersensitive pneumonitis, acute eosinophilic pneumonia. All these have a relation towards involvement toward the lower lobes. If you are dealing with an upper lobe pathology in CT, then you are thinking in terms of it could be even sarcoidosis, it could be silicosis, occupational lung diseases. Then we have chronic hypersensitive pneumonitis or chronic eosinophilic pneumonia. So the discriminators, IPF or UIP, you have a basal reticulation, there will be clubbing. Sarcoidosis, the highlight is by hilar lymph nodes. Calcium is not commonly seen, but it might be elevated. You have ACE also, serum ACE levels to look for in sarcoidosis. Hypersensitive pneumonitis, you have always an antigen exposure. So unless you are able to prove the antigen exposure, you cannot diagnose a hypersensitive pneumonitis. Up to the zones depend upon the chronicity. If it is an acute, you will have a lower lobe involvement with air trapping, ground glassing, and interlobar septal thickening. If it is an upper zone involvement, then it is more of a chronic. So what are the key tests? IPF, almost always HRCT itself is enough. In case of doubtful UIP pattern, you will have to go for a biopsy. Again, in hypersensitive pneumonitis, you have exposure, identification of exposure, then the precipitants in blood tests. Management in IPF, we have discussed before, it is antifibrotics. In sarcoidosis, we have steroids if clinically indicated. Then hypersensitive pneumonitis, the main thing is to avoid steroids. That means avoid antigen exposure and to give steroids where indicated. Again, dry cough, uveitis, erythema nodosum, hypercalcemia, look for sarcoidosis. So here, a 39-year-old presents with dry cough, bilateral hilar lymphadenopathy on chest X-ray, adjusted calcium levels is 2.9, anterior uveitis. He is symptomatic. So what would be the treatment of choice here? We know the diagnosis, we know the treatment of choice here. Okay. So this is just recapping what we have discussed so far. ABG, first line, we have to look for the pH, then decide whether this is respiratory or metabolic. If it is metabolic, look for the anion gap, so that will help us narrow down the differentials. Eosinophilia, we are dealing with ABPA, eosinophilic pneumonia or EGPA. Massive pulmonary embolism, then we have to intervene, altiplase. Stable pulmonary embolism, we have to anticoagulate. Large pneumothorax, along with hypoxia, chest strain, tension pneumothorax, needle first. So again, there's a correction here because of the updated BTS guidelines. This is based on the symptoms. Okay. Then sarcoidosis with symptoms, or there is increased calcium, you have to go for steroids. Coming to medical ophthalmology, this carries 1.5% of the total marks. So these are all straightforward questions mostly. So small share, pure sport diagnosis. Okay, so there could be field defects which will help in localizing lesions, retinitis pigmentosa, uveitis, sudden painless monocular loss, along with atrial fibrillation or carotid. So those things we'll be discussing. So coming to the visual field defects, in case of optic nerve defect, that the complete supply to the nerve, to the eyeball. So there is a monocular vision loss. If it is optic chiasma, that means that is in the center. So you will get bitemporal hemianopia. So what is the structure there? We have a pituitary. So it would be an enormous enlargement of the pituitary gland. It would be adenoma. You have to get an MRI. If it is an optic tract, then you will get a homonymous hemianopia. If it is optic radiation or cortex, then you have homonymous photonopia. Okay. So, or hemianopia, depending upon with microscope. So coming to fundoscopy and systemic disease. Diabetic retinopathy, what are the features that we see here? So microaneurysms, dot plot hemorrhages, hard exudates, neovascularization. So it would be better if you go back and read about the different stages in diabetic retinopathy, so that those questions might be important. Hypertensive retinopathy, you will have AV nipping, flame hemorrhages, cotton wool spots, and papilledema. In papilledema, you'll have raised ICP. Image, you have to go for imaging of the brain. Consider idiopathic intracranial hypertension in young obese females. So this is an important question. This can come even in cases. A female around the age of 40 years who is obese, presenting with vision loss, or blurring of vision. So we have to, or headache. So in such cases, we have to look for idiopathic intracranial hypertension. Growth spots can be seen in infective endocarditis or vasculitis, optic neuritis, painful loss, related to afferent pupillar defect. Then think about demyelination. MS is a favorite question in multiple sclerosis because of the varied presentation. Okay, from top to bottom. So eye signs in systemic disease. So this is also an important topic because many systemic disease can present with eye manifestations. Bitemporal hemianopia, you have to know that this could be a chiasma lesion. So there could be pituitary tumors. So MRI and pituitary screen. Bald specular pigmentation. So this is classical of retinitis pigmentosa. So this is an inherited disorder. So there is no absolute cure for that. You have to counsel the patient and the parents. So anterior uveitis, it could be sarcoidosis, HLA-B27, seen in Behçet's disease. Okay. Then what are the HLA-27? So these are seronegative arthritis. So those patients also can present with anterior uveitis. Treat cause and ophthalmology reference. Then painless monocular loss, and that we are dealing with retinal artery occlusion. So we have to identify the embolic source and address it. So there is a 34-year-old reports night blindness and tunnel vision. In fundoscopy, you get peripheral bond spicule pigmentation, attenuated blood vessels, and a waxy disc. So several relatives are affected. So this is the pattern that we see typically in retinitis pigmentosa. So what are the things that we see? In early changes in retinitis pigmentosa, the symptoms will be loss of night vision. So in the sense, in dim light vision will be anecdosis. So it is necropia along the peripheral field. So that is what we call a tunnel vision. And fundoscopy classically defines the bond specular pigment. Okay. So what is the trap here? Glaucoma has cupping and raised pressure, artery occlusion, or with a macular degeneration causes sudden or central loss. So this is a rapid revision. Bitemporal hemianopia, you're dealing with pituitary problem, you go for an MRI. Bond spicule and night blindness, then you're dealing with retinitis pigmentosa. Anterior uveitis, you're thinking in terms of sarcoidosis or the seronegative arthritis or Bishop syndrome. Then painful lows or RAPD, you're looking for optic neuritis, like in MS. Painless monocular loss plus AF, retinal artery occlusion. Coming to palliative medicine, so this also constitutes 1.5%. So palliative end-of-life symptom control. So these are all factual questions. There's no confusion in that. Recognize the dying phase and shift to comfort. So in such cases, we have to stop the non-essential medications, unnecessarily investigating the patient further, or administering the drugs should be avoided. So match symptom to subcutaneous agent. Okay, I will be discussing that further. Pain and breathlessness, the treatment of choice will be opioid. So this is not only in case of malignancy, this can be extended to other causes like severe cases of interstitial lung disease or COPD, when patient is having persistent breathlessness even with maximum medications, like more towards an end stage of the disease. In such cases, we have to administer opioids, which can ease the breathlessness part. Terminal agitation, in such cases, we have to relax the patient by administering subcutaneous midazolam. Secretions, we have to reduce the secretions by, typically what we use is antimuscarinic agents and repositioning the patient to prevent the aspiration. Explain to the patient and to the family. Okay, so this is the WHO analgesic ladder. In step 1, we have non-opioids, mild pains. You can start with paracetamol or even NSAIDs. Next step, we can add on weak opioid along with or without non-opioid. In step 3, we have a strong opioid like morphine with or without a non-opioid adjunct. So climb the ladder by pain severity, add adjuncts adjuvants at any step. So subcutaneous symptoms, the drug map. So if the patient is having, this is the summary of what we have already discussed. If the patient is having pain or breathlessness, we can use opioid. If we have oral also, and we can give subcutaneous morphine also. And terminal agitation, we have subcutaneous midazolam. Then respiratory secretions, we have antimuscarinic agents. We prefer here like a paraneoplastic. Nausea or vomiting, antiemetic by mechanism. You can give haloperidol, cyclizine, or tocilizumab. Sedation drivers and anticipatory prescribing. So continuous subcutaneous infusion delivers a steady symptom control when oral route fails. Anticipatory drugs like opioids, antiemetics, anxiolytics, and antisecretory. So these are the just-in-case medications. Opioid convert oral to subcutaneous and account for renal impairment. So what is a breakthrough dose? It is of this opioid. That means 1/6 of the 24-hour opioid total. Okay. Nausea, use antiemetic by mechanism. So coming to the practice question here. A woman with end-stage lung cancer is in the last stages or days of life. She is distressed and agitated with ongoing small volume hemoptysis. The family asked that she be kept comfortable. So what would be it? So this is an end-of-life scenario. Patient is distressed and agitated. So you know the answer. We have to keep subcutaneous midazolam because terminal agitation in the dying phase. Sorry. Now, opioids again, we know that it's used to treat the pain or breathlessness, not agitation. So we are not dealing with the bleeding here because whatever we do, there is a limit to address the bleeding. So again, a rapid revision. We have terminal agitation and case of septicness, midazolam we can administer. Death rattle, we have that means excessive secretions. Then we have to give antimuscarinic agents and reposition the patient. Pain or breathlessness, opioid. Then nausea, antiemetic by mechanism. Dying phase, comfort care, palliative care, referral. We have oncology now. This constitutes almost 3% of the total. So we are dealing with oncological emergencies first. So time critical 6. So what are the things that you should look for in oncological emergencies? Neutropenic sepsis, port compressions, hypercalcemia, more of a paraneoplastic, SVC obstruction, tumor lysis, raised ICP. In neutropenic sepsis, we have fever, patient presents with the fever along with neutrophils less than 0.5. And broad spectrum antibiotics should be administered within the hour. Hypercalcemia, confusion, polyuria, constipation. Initial administration of IV fluids followed by bisphosphonates because bisphosphonates can take time to act. Tumor lysis syndrome, we are looking at high potassium levels, phosphate, urea, low calcium, fluids, and raspberry cases of freedom discharge. SVC obstruction, facial swelling, distended veins. Then a chemotherapy with steroids with or without stenting. So these are the summary of oncological emergencies. If the patient presents with fever and neutropenia, you're dealing with neutropenic sepsis. Broad spectrum antibiotics need to be administered within the hour. Back pain, leg weakness, or retention of urine, you are dealing with cord compression. Okay, so what do you have to do? MRI is fine, steroids in the meantime, and whether required to operate or not depends later. Patient presents with confusion, increased calcium, and on the background of malignancy, you are thinking in terms of hypercalcemia. What do you have to do? IV fluids and IV bisphosphonate. Facial swelling and distended veins. This is a classical picture of SVC obstruction. So this is usually seen in patients with mediastinal malignancies or lymph nodes which is compressing onto the vessels, or it could be because of apical tumors. So we have to give chemotherapy along with steroids with or without stenting. So neutropenic sepsis and spinal cord compression. Neutropenic sepsis is act first. So even if we require the cultures, antibiotics need to be administered first, and cultures can even be taken after the first. That is because antibiotics need to be given first. Then risk stratify using MASCC scoring system. So the MASCC is Multinational Association of Supportive Care in Cancer. So this predicts the risk of serious complications. So that is, if the patient is having a high MASCC score, then there is a risk of serious complications. If it is low, patient may be suitable for early discharge or oral antibiotics. It is the other way. If the patient is having a high MASCC score, that means the patient is having a low risk. That means patient may be suitable for discharge and with antibiotics or oral antibiotics. So now, in case of malignant spinal cord compression, the back pain patient presents with along with the new leg weakness or bladder bowel dysfunction in cancer patients. Okay, so in such cases, immediately we have to administer dexamethasone and whole MRI, whole spine MRI within 24 hours, and oncology or spinal specialist referral. Delay risk, if you delay, there could be irreversible paraplegia. So treat before imaging confirms with dexamethasone. So this is the pathway: cancer with back pain and a new onset leg weakness or retention. Suspect metastatic spinal cord compression. Immediate dexamethasone, lie flat and analgesia. Whole spine MRI within 24 hours. Refer for oncology or spine surgery. So here is a 58-year-old, day 10 after chemotherapy for lymphoma. Presents with 38.6 degrees Celsius at rigors, no localizing symptoms. So WBC counts 0.9 along with neutrophils of 0.1. So we know the answer to the question. So what would be the appropriate treatment of choice here? So we have IV Brazilian tazobactam now because this is a neutropenic sepsis. Empirical broad spectrum IV antibiotics within the hour. Waiting for cultures or using oral or narrow agents delays life-saving therapy. So paraneoplastic syndromes. So this is also an important topic. So Lambert-Eaton myasthenic syndrome has proximal weakness improving with the use. So what happens here is the antibiotics attack the VGCs, that is voltage-gated calcium channels. So the less calcium enters the nerve terminal, and as a result of that, there is less release of acetylcholine. But after repeated stimulation, what happens is that there is a more calcium accumulation and more acetylcholine release, and the patient improves in symptoms. So this is the difference between LEMS and myasthenia. Whereas in myasthenia, repeated use reduces the muscle strength. Okay? It improves muscle strength. So this is usually seen in small cell lung cancer. Towards treatment of choice here is initially supportive. You can give 3,4-diaminopyridine. Okay. So why do we give diaminopyridine? Because it blocks the presynaptic potassium channels. So the action potential lasts longer. So more calcium enters the terminal, more acetylcholine is released. Limbic encephalitis can cause confusion, seizures, amnesia. It is the marker here is anti-HU, seen in small cell carcinoma. So if you see small cell carcinoma, there are a lot of paraneoplastic syndromes. Anti-NMDA are encephalitis, psychiatric features along with seizures seen in ovarian sarcoma. Cerebellar degeneration, again anti-EO in breast and ovarian cancer. Endocrine, you have SIADH in small cell lung cancer, ectopic ACTH, and hypercalcemia, parathyroid hormone-related peptide causing. So this is seen classically in SCAPA. So my suggestion is that you read the important points, like in squamous cell carcinoma we have hypercalcemia, and the rest of the things you can relate it to SIADH. So this is a summary of what we have. Small cell carcinoma, we have LEMS and limbic encephalitis. In ovarian teratoma, anti-NMDA receptor, you have encephalitis with psychiatric features. Cerebellar degeneration, anti-EO in breast and ovary. So 67-year-old smoker with small cell lung cancer reports proximal leg weakness that improves after sustained effort. No, the diagnosis is clear. Reflexes are diminished but increases after exercise. So what would be the treatment of choice here? We have 3,4-diaminopyridine. That is the mechanism we have discussed before. So Lambert-Eaton myasthenic syndrome, because this increases the acetylcholine release. So pyridostigmine helps myasthenia gravis, not LEMS. Okay, so the kind of confusion they can bring. Again, a 70-year-old with squamous cell carcinoma, squamous cell carcinoma means paraneoplastic, we are dealing with something. With confusion, constipation, polyuria. Adjusted calcium is 3.4, renal function is preserved. So what do you do next? So we know that at first we have to administer fluids followed by IV bisphosphonates. Okay. So again, loop diuretics is not the first line. We don't want to drain the fluid. We have to administer the fluid. Oral bisphosphonates, again, it is too slow, so we are giving it IV. In extreme cases, you have to go for dialysis. Okay, so this is just a summary of what we have discussed, the do's and don'ts. Never give a beta blocker for AF with acute severe asthma. Thrombolyze a stable small PE. Aspirate a large pneumothorax with hypoxia. Again, delay antibiotics in neutropenic sepsis. Image before steroids in suspected MRCP, that means the cord compression. Treat sarcoid hypercalcemia with calcium or vitamin D. Okay, so what you should do instead of beta blocker, you have to give verapamil or diltiazem. In a stable patient with thromboembolic, don't thrombolyze. Only for hemodynamic compromise, you should thrombolyze. And regarding the aspiration, you have to treat only the patient who are symptomatic. You can decide on aspiration or chest drain. Then delay in antibiotic of neutropenic sepsis. You have to always go for antibiotics at the earliest. That means within the Okay, in MRCP, you have to administer dexamethasone, then get an MRI. In sarcoidosis, if the patient is symptomatic or if there is any organ involvement or if there is hypercalcemia, you can administer corticosteroids. So in cardiology, this is just a summary. Code ST V1 to V3 along with nocturnal sudden cardiac death or family history, you have to suspect Brugada syndrome. The treatment of choice is ICD. Post PCI isolated QRS, widening, stable, observe. So this is usually seen because of reperfusion arrhythmia. And if there is a low ejection fraction along with left bundle branch block with symptoms, you have to think in terms of resynchronization therapy, with or without defibrillator, depending upon the rhythm. AF with asthma, then the drug of choice would be verapamil or diltiazem. Regular narrow tachycardia around 150, you have to think in terms of flutter. Long QT with low potassium or magnesium, Torsades, IV magnesium would be the choice. In Beck's triad, pulses paradoxes, look for tamponade. Coming to respiratory, we have discussed this. Aspergillus, asthma in the background, and aspergillus, you have to think in terms of ABPA. Treatment of choice would be steroids followed by etripamil. In COPD, NIV, you have to increase the inspiratory pressure if the next RABG is not showing any improvement. Pleuritic chest pain, hypertension, and so there is a correction here. If the patient is hemodynamically unstable, the RV strain is not included here. So if there is a hemodynamic instability, then you have to go for alteplase. So last, again, there is a correction here. Depending upon the symptoms, we have to go for chest drain. And the drain of chest or the pneumothorax drainage, either by needle decompression or needle aspiration or chest drain, have nothing to do with the size of the pneumothorax. And bilateral hilar nodes with high calcium and dry cough, we are thinking in terms of sarcoidosis. Normal or rising carbon dioxide in acute asthma, then we have to refer the patient to ICU. Like I said before, we have to focus on the word normal here, because even a normal PCO2 is not accepted in patients with acute asthma. And tension pneumothorax, we have to go for needle decompression. Ophthalmology, we have bitemporal hemianopia in pituitary lesion. We have to go for an MRI to look for any pituitary tumors or adenomas. Bone specule fundus with night blindness. You are thinking in terms of retinitis pigmentosa. Painful loss along with RIPD, optic neuritis. Anterior uveitis, sarcoidosis, then or any seronegative arthritis, then Behçet syndrome. Terminal agitation, always go for subcutaneous metazolam. Increase in secretions, we have to give for antimuscarinic agents along with repositioning. In dying phase, the ultimate goal will be to comfort the patient and palliative refer. Neutrophils less than 0.5 with fever, we have to administer antibiotics within the hour. Back pain and neurology in cancer, then we have to get MRI, administer dexamethasone before. High calcium in malignancy, we have to administer IV fluids followed by IV bisphosphonate. Okay, again, weakness improving with the use. We are dealing with the paraneoplastic here. Weakness improving with the use with small cell carcinoma. And then we are dealing with Lambert-Eaton syndrome. The treatment of choice is 3-4 TAP. Anti-Hook limbic encephalitis is associated with small cell carcinoma. Like I said before, most of these paraneoplastic syndrome will be associated with small cell lung cancer. Then anti-NMDA with psychiatric features, we have ovarian teratoma. Facial swelling with distended veins, we have SPC obstruction. So this is again, like I said before, it's a medical emergency, oncological emergency in fact. The patient presents with sudden onset breathlessness, chest pain, facial swelling, distended veins because of SPC obstruction. So the treatment would be chemotherapy and dexamethasone. So these are the sources you have to go through. So like I said before, these are the upcoming events by StudyMRCP, by StudyMedic. So we have the PACES training programs. We have 2-day live on-site course as well as one-to-one courses. You can contact the operations team for further information. Okay, then if you don't have any doubts, we can end the session. Thank you all.